Mr. Young?
Yes.
Mr. Grossman?
Yes.
Great. You're on. We're gonna hear from Tammy Whitaker, our benefits administrator, relative to our 2024 insurance renewal, and your full litany of cast of characters here.
Yeah, so Haran is now Hub. So that transition, that name transition, we have Faith Stone, she's our administrative assistant.
Wait, Hub bought Haran?
Yeah, we're up Haran right now, so next year we'll probably go to
Interesting.
So anyway, we're here to talk about our plan for next year, so our 2024 healthcare plan. We're getting ready to open up enrollment on November the 13th. It'll go to the day before Thanksgiving, so we'll get real busy after the board makes some decisions on our plan for next year. So I'll go ahead and turn it over to Haran. Allison.
Thank you, Tammy. Good morning, everyone.
Good morning.
I'm Allison Ruhlman. I know I've been here in the past to go over some benefits information, so thanks for having me. And Tiff, I guess this is one of our last ones together, right?
It'll be my last.
Yes.
My last time that I get to fight with Dave on Star
Well, we gotta end it on a good note then, right?
I think you'll be fairly happy this time, maybe.
Hopefully, fingers crossed. So today we have a lot of information to go over, so I know in essence of time, I just want to make sure that we get through all of it. So I'm going to go pretty briefly at the beginning, and we'll get into the recommendations. Just briefly, agenda, this is what we typically go over, historical information, then we're going to get into what we have for the budget for 2024, and then overall recommendations and strategies moving forward. So really briefly here, this is going to give you a historical analysis, something we provide every year. Just really the big thing we want to show you on this slide is looking at how Warren County has ran over the last 11 years compared to trend. So big thing, looking at the cumulative cost difference over the last 11 years, that difference is about $32 million. If we average that on a per year basis, it comes down to about $2.9 million. So although we've had some, years that are higher than others, when we look at it from a cumulative standpoint, you all are running much better than trend.
So when you say 32 million or 2.9 million a year, that is the cumulative amount that we're below market and the yearly amount we're below market.
Correct,
Okay.
Exactly. Looking at overall your claim spend and your fixed costs, so like the stop loss premium, administrative costs that you pay, United Healthcare, that total cost together, the difference between trend and how you all are running.
Okay.
Yep. All right, so a lot of information on this slide. So briefly, just 2023 renewal recap of what we did moving into 2023. I won't go through all of these, but essentially from the medical perspective, you all are in a rate hold with United Healthcare. We'll talk about that a little bit later. Some of the big things that you did in 2023, one of those big items was implementing that 4-tier contribution strategy, moving from that 2-tier. We added another additional HSA contribution, and then we also implemented that expanded preventive RX drug list. So we'll talk about that a little bit later as well. Stop loss, we did have a 9.2% increase to premium. That original renewal was a 47%, which equates to about $160,000 in premium. Overall, we increased that stop loss deductible, and I will tell you, looking at your experience, that was a good decision, increasing that liability based off of how your large claims have been running. Although we do have large claim frequency, not to that level. So overall, Warren County did win by increasing that specific and then lowering that premium.
I agree with you on that one.
Yeah, we were all in agreement there.
That
Yeah,
wasn't
I
the
agree with
dispute.
you on that one. Now, doing away with stop loss altogether,
That was the dispute.
that's the rumble.
Yeah, and then just dental and vision, we did increase the dental annual max, and then we increased frame allowance. That was all some of the basis from the benefits committee, working with book club and thinking of ways that we can improve the benefits overall. All right, so we're going to get into 2024 here. First off, just want to give you what that projected cost to the total budget looks like. From the county perspective and just from our conversations, the overall increase by department is suggested to be at 4%. As we evaluate with Tammy and Martin and the team, looking at how things are running, obviously from a claims perspective and just overall increase in utilization, we do feel like that total budget increase is going to be more suggested around that 7%. Based on how you are running today in 2023, you are exceeding budget, right? So if we're thinking about what that excess in budget is compared to what that 7% increase is, it actually looks to be more about 11% increase, right?
But I thought you said we were running below trend.
You overall, cumulatively, looking at the last 11 years, yes, you have ran below trend. But, there's other factors into that of, what you've budgeted year over year based off of where your claims are, those type of things. Overall, I will tell you trend in the market is around a 7 and 8% increase year over year. So you've had years where you've had a negative, where you've been running extremely well. You've had other years where it might be a little higher. So it's going to ebb and flow depending on the year, but when we look at it from a cumulative perspective, that's where you've significantly ran below trend. And there's a lot of things that go into that budget. It's not necessarily just claims. Claims are a big portion of that expected budget overall. But when we think about, the fixed costs, the premium, administrative costs, consulting fees, wellness fees, for your wellness vendor, those type of things all go into that budget that Tammy has. The next few slides, we're going to talk through, what are some of those strategies and recommendations to get that percentage down as much as possible based off of how we are running today. I will tell you, as we're thinking, we are exceeding budget. The reason for that, I did mention we're winning on the stop loss front. When we look at your large claims frequency for claims from $25,000 to say $200,000, $225,000, there are more claimants now than we had last year in those ranges. They're not stop loss hits by any means, but they are increased utilization, increased frequency on your plan. All right. So really quickly on the fixed medical renewal. So these are things that are already, your fixed premium costs. Your UHC administration, I mentioned you're in a multi-year contract with United Healthcare. Based off of that multi-year contract, your admin rates are expected to increase 4% based on that contract. That equates to about $20,000. And then stop loss, as it stands today, we have some alternative options that we're going to go through, but the original firm renewal comes in at about 10%. That equates to $37,000 in premium increase. I will tell you stop loss trend is around that 18 to 23%. So we have not had any stop loss reimbursements this year, knock on wood. And then just looking at, alternative options, we do have some competitive items to share. All right, so let's start with stop loss, everybody's favorite topic.
Dave leans in for that one. Okay.
So there's a lot going on in this slide, but I wanted to make sure you had all the options that are firm options in the market, right? None of these are illustrative. Stop loss carriers want as much claims data as possible before they release firm data or firm quotes. So this is all data through September. As I mentioned, your renewal is that 10.2%. So you see that red box on that top chart. That is if you were to keep your specific deductible and your aggregating specific deductible exactly where it is today. You will see right now you have a lasered claimant. That one is at $850,000, meaning that their specific deductible is higher than that $300,000. I will tell you where that that lasered claimant today has hit around $240,000 through September. So they are nowhere near that lasered amount, which is a good thing, right? They have not hit nearly close to what was anticipated.
Is that annualized or aggregate cost of the claim?
The
one person, is that $240,000 a year, or that's $240,000 over the life of the claim?
So the laser claimant is at $240,000 through September.
just for
This
this year.
year.
For this
So
year,
each year, so that's $1 million, $2 million claim.
In 2022, they hit $1.7 million. So it was a,
Stop loss.
yeah, we had a lot of stop loss reimbursement that year.
You're gonna miss me, aren't you?
2023, yes, through September, they are at $240,000. HCC, Tokyo Marine, is your stop loss carrier. They have taken that laser off of the renewal, and they have added a new laser on at $500,000. What I will tell you about this $500,000 laser, it is a dependent. They are 5 years old, and they have spinal muscular atrophy, SMA. The reason they are lasering this individual, they've only had $90,000 worth of claims this year. The reason they're lasering is because I'm sure you have heard through, pharmacy, gene therapies are becoming very popular. I would say that they're not very prevalent. Obviously, you might just have one hit for one employer in maybe 10, 15 years. But when one of these gene therapies hits, it can cost over $1 million, $2 million, sometimes all the way to $3 million. There's only a few gene therapies FDA approved today. Some of those are for, Roctavian for hemophiliacs, childhood blindness, and then another one is that spinal muscular atrophy. These are life-changing therapies because they have them and they are completely cured, hopefully, where, you hit this big $2 million charge and then that individual is cured and there's hopefully no more claims expenditure in the future. Where this dependent is right now, they are 5 years old. Typically for these gene therapies, they are taken when they are an infant or when they are born. So this gene therapy was just released recently. As you can see from some of these other quotes, they're not even noted about this specific claimant. I will say from a risk perspective, overall risk of having this gene therapy on your plan is pretty minimal. They are just being pretty conservative about it in case it were to hit. Like I said, at 5 years old, I doubt that they would have this. And you all being a self-funded plan, you have the option to determine if you would want that gene therapy to be covered or not. Obviously, it is life-altering. It is curable for that individual. But like I said, I think it would be minimal risk. I don't think that they would actually have that. So HCC, like I said, they removed that $850,000 laser. I will say, they are at $240,000 through September. However, they did have an inpatient readmission in September, and we do anticipate that claims continue. Not sure if they will hit that level or not, but there will be readmissions due to, it was a liver transplant a few years ago. So things to think about there. If you would like to stay with HCC Tokyo Marine, they did give you obviously the renewal and then an alternative option, kind of like we did last year, where we increased that specific stop loss deductible, and that would go to $325,000. If you were to do that, aggregating specific remains the same, and if you look at your total annualized premium for 2024, it actually is below current by about 2.5%. Those are both firm offers from HCC Tokyo Marine. I will say, looking at your large claimants, so you're like, okay, what's the risk if we were to increase that specific? You only have one claim through September over $300,000. They are around $400,000 spouse on your plan. Other than that, there are no claims in that threshold. So when you're thinking about risk over premium, obviously increasing the specific, any large claimant that hits that, that's going to be an additional $25,000 risk. If you had that today, you only have one person over that. So it would be the same thing as today, essentially. There are some other options on the table, which is good. Sometimes we don't get competitive options. So we do have a couple of vendors who have submitted quotes. We did have a few who declined. We had 9 that declined to quote due to where your premium is today. But you can see 180 intermediates and SA benefits also quoted. These are if you were to keep your specific deductible where it is today. They kept your same laser that you have today. SA benefits did increase that laser liability by $25,000. But you can see that those are still fairly competitive if you wanted to keep things kind of, where they are today from a specific deductible standpoint.
Yeah, so like the SA benefit looks like it would almost be our current plan at basically the same cost.
Yeah, except for that increase in the laser, which we mentioned, they haven't gotten close to that amount yet.
Yeah, it's only 25 grand. though,
Right, correct. So yeah, to that point, Commissioner Young, looking at the HCC alternate, the $325,000, that would be for every single large claimant. With a laser, it's just that one individual if they hit that amount.
And they're lowering that.
Well, SA would keep the $875,000. HCC is removing that
It's
laser.
removing.
But the specific stop loss deductible, the lower that is, the more we're protected, right?
Correct.
So 300,000 versus 325 is better, right?
Correct.
But can I ask something else? On the additional 25,000, that really, the difference in 300 to 325 really doesn't mean anything unless if we meet that aggregating deductible, right?
Correct. So you still have that aggregating specific deductible in place. Today, you have not exceeded that, so no stop loss reimbursements. And based off of your data today, we have only one large claimant that's exceeded your specific deductible. So as far as, the 300,000 compared to the 325,000 today, it's a moot point for you all because you've only had that one large claimant. If you do have additional large claimants in the future, that's when there's additional risk and liability to the county.
And Allison, there are two different people making up, so I know you said obviously a child on the 500. Is it also a child on SA benefits as well? So it's the same large claimant in both scenarios, correct?
There's two different dependents. So you have one, they're two different people as far as the lasers.
Oh, okay, so the 500 is the child, the 875 is the previous one, correct?
Yes,
Okay.
exactly. Yes, and
So
so,
with that alternate proposal, they're not lasering out the child.
correct. So the alternate proposal would keep the same laser you have today, and they are not lasering the child.
Which again is a better proposal, right?
I would say, as far as the laser liability is concerned, the lower the laser, the better liability, right? Because overall, if that specific laser gets to $800,000, it's on the county to obviously pay for that until you reach that laser liability. However, it just depends on, the utilization of that laser individual. Today, they haven't even exceeded half of that amount.
Readmission currently?
I'm sorry?
They have readmission currently?
They had a readmission in September, correct.
Sure, but it seems like you're kind of talking down our potential risk on that one claim, but I'm still looking at it from a macro standpoint of the parameters, at least on the surface, maybe seem to be better. In Tokyo Marine, because we haven't dug into our stop loss, right? But yet they're still hitting us with a 10% increase. So it's good that they've been around for a few years, but that's where we've developed a track record, and we have not hit our stop loss for quite a while, correct?
So you have hit, I'll go to the slide really quick and we can go back here. This is going to give you your historical stop loss information. 2022, as we mentioned, that laser claimant did hit over $1.7 million. You had about $1.2 million in stop loss reimbursements in 2022. So when you look at that total loss ratio for Tokyo Marine, they did get hit in 2022. However, overall in your partnership with them,
Oh, they've killed it.
yes,
They're up about $500,000.
Yeah.
correct.
Right now, they're up about $500,000.
Yeah. So yeah, I think it's kind of just identifying from a risk perspective. Would you like to take the additional risk for individual claimants on the $325,000, or keep that at where it is today and take the additional risk on a laser liability if they were to exceed?
But on both of your alternatives, the 180 and the SA, both those are very, very, we're not really changing any of our parameters though, right?
Correct.
It almost seems like you don't, are you not encouraging us to look at those?
No, I would say they're very, very competitive offers on the table. I will just say that the laser liability is $300,000+ more. And from looking at the claims data and the prognosis for that lasered individual, they're not going away anytime soon. I don't know if they're going to hit that $800,000, but we do know from clinical notes and from the medical director at United Healthcare that there could be more hospital admissions, and we just don't know the complications that could come with that.
Allison, can I ask a question? On the 180 and the SA benefits, just so we're making sure that we're clear, the laser is for the first child with the liver transplant.
Correct.
So it does not include what might be relative. So if we take the new spinal, can you say
Spinal
that?
muscular atrophy,
Okay.
yeah.
If we take that one and it increases, it will go into our normal specific and aggregate because they are not lasered out.
Correct, exactly.
So I think that we just want to make sure, I want to make sure that
Yes.
we know which dependent is which laser.
Yes. So HCC Tokyo Marine, the 500,000 would be a completely new dependent laser on the plan, and they would remove the one that we have today.
But if the new person does have the gene therapy, even though you say the odds are slimmer,
Yes,
right now they would be covered. They're not lasered, and they would be covered under the specific and the aggregate.
Correct.
So our risk in some respects, that number is still lower.
correct,
Wait,
exactly.
I don't understand that then. So if we have the child that they are saying this is a new laser at $500,000 and it is a $2 million therapy, we're on the hook for 1.5 million, right?
Their laser is 500,000, meaning that, for every other individual today, their specific deductible is 300,000. So after they hit the 300,000, you go into aggregating specific, et cetera. For that specific individual, theirs would be 500,000. And then
Okay.
after, that's your liability for them is 500,000.
So it's just a specific increase in out-of-pocket, it's not, we cover everything above that?
Right.
Correct,
right.
yes. It's just they have basically their own individual specific deductible, and everybody else has the 300.
So the 500 is actually lower than the 850
Yes.
on
Correct.
the new one?
Correct.
It's out of pocket.
Yes. And so if you think of it that way, if we know that the laser today that's on the plan, we know that they are active and they could have potential admissions in the future. If they are not lasered in the future with Tokyo Marine, it basically limits liability on the county because it's going back to that 300 or 325,000
I'm
specific.
surprised that they're removing that laser
I am too.
because that is, a transplant, just the cost of drugs and so forth. That's just sort of really surprising.
And
to me.
those are
1000%.
firm quotes, so they're not waiting on any additional information, where the other ones, I believe we will have to update that information.
They're all firm.
They're
And
all
those-
firm now.
Oh, they are,
Mhm.
okay.
Yep.
And
They
so
wanted to
they're
September.
keeping the laser on there for the child with the transplant,
Mm-hmm.
but they have not said anything. It is silent around this potential new risk that they're not looking at, so
Mm-hmm.
they would be a part of the.
I will say too, my contact at Tokyo Marine, he's not in underwriting, so he gets, the quotes from underwriting, and he has the same opinion as you, Commissioner Jones. He's like, I'm very surprised that they
Yes.
took that off.
And that to me is in my mind the reason not to shop, to take one of these other offers, but because the gene therapy really, is not an unlikely therapy given the age of the child. But this transplant's actually happened
Correct.
and requires lifelong
Yeah.
maintenance.
And to see an alternative quote increase that to 875,000, obviously their underwriters are looking at something too.
They must have been hit on that gene therapy hard.
So
So you're saying that the Tokyo Marine alternative is our best move?
I would say from our recommendation, yes. from keeping your premiums as competitive as possible and your risk on the plan as minimal. Looking at how your utilization is today, as I mentioned, you've had only one claim exceed that's specific at 400,000. So really from a risk perspective, it would be the same as it is today. So yeah, that would be my recommendation.
Which is fine with me, because again, this has been, what I've been trying to do is self-insure more of this, and it is work. I mean, there is, you showed the slide before, us
Yeah.
taking on more of the risk has reduced our premiums compared to what they once were.
Yeah.
And yet, we, everybody's won in that scenario. Our stop-loss carrier has performed well, and we have saved a boatload in premiums by taking on more of that risk.
Correct.
And that is just a fact.
Even looking at 2021 to 2022, if you look at that blue box, you can see the annual stop-loss premium was around $336,000 for both years. Your stop-loss premium went up slightly. It was less than 5%. However, you had enrollment fluctuations. So with enrollment, people moving from family to single kept your stop-loss premium exactly where it was the previous year. So yeah, Commissioner Young, to that point, it has remained pretty stable. Any other questions on that?
So we have direction to move to the HCC alternate.
That's the one you recommend.
Correct.
I'm happy with that.
I'm happy with it too.
Dave?
Yeah, it's fine.
Okay. All right. I'm going to get into some more recommendations. There are a lot of slides here, so I'm going to go through pretty quickly, but I want to get into some of the medical plan and pharmacy heavily here. The medical plan recommendation that we have on this plan, or in this slide, is in regards to plan design. So as Tammy alluded to, and myself, about the budget, when we're thinking about how we make sure we keep that as steady as possible, one option is increasing deductibles for your plan design. Today, you have two high deductible health plans. You have a base and a buy-up. The base is at $3,000, $6,000 for your deductible. Your buy-up is $1,750, $3,500. One thing I will tell you that has to happen, regardless, due to the IRS, is your base plan deductible will need to increase to $3,200 and $6,400 for family due to IRS regulations. They increase that typically every year, and you're at that base level where you will have to increase that. As we discussed that, they do annual increases, so we thought if we increase that a little bit more to $3,500 and $7,000, and then we reflected the out-of-pocket maximums to match that by 2 times, like we aligned to last year. That plus, if we are going to increase that, potentially increasing the buy-up plan slightly from that $1,750 to $3,500 family to $2,000, $4,000, and matching out-of-pocket by 2 times. Making those changes provides an estimated $360,000 decrease to the county spend. So overall savings to the county. That's based off of utilization today, obviously of people who have hit out-of-pockets, et cetera. But as we think about budget increases, this is one that could provide a significant savings to the county.
We consider the option of employee spouse as another category?
You do have a 4-tiered, oh, you mean on a deductible?
We do for rates, but
Yeah.
not for deductibles. It's either single or family. Is that what you're asking?
Yeah, because it's like, okay, you've got a single, and then you've got a family, which can encompass anywhere from 3 people to 8 people,
Right.
and
Right.
yeah, I have a feeling there's a lot of employees that are just spouses.
Yes. One thing that
Yeah.
your plan is embedded, and what that means is it could be embedded or non-embedded. Embedded is more favorable, meaning that after one person, if you are in a family plan, say it's just employee plus spouse, or you have your whole family, after you hit the individual single deductible, that specific individual essentially is covered, for their expenses, right? So it's kind of like an individual plan and a family plan in a way. So that also helps when you think about, the favorability of your plan compared to other high deductible health plans.
Because you're not paying out-of-pocket premiums to cover all of them if you're in the buy-up plan, you're just paying out-of-pocket to cover.
Oh, exactly, yeah, if you're thinking about from a contribution perspective too.
That makes sense.
Totally, yeah. So what I will tell you about this increase, obviously from an out-of-pocket maximum perspective, this is only going to affect the people who are utilizing the plan, right? So when we think about making changes to employee contributions to the plan and what's coming out of their paycheck, this is really something that's only affecting if somebody's utilizing the plan, not necessarily everybody on the plan. The out-of-pocket maximum, if it does go up, I do have some benchmark data there on the bottom to show you. Yes, the out-of-pocket maximum, specifically when we look at, the base plan, is higher than benchmark, right? But what I will tell you is when we look at the contributions and that, the percentage that employees pay is very rich at the county compared to on the state or just your industry level.
Well, yeah, because again, even if our single employee totally utilizes the plan and it costs them $2,000, in a real world sense, that's $166 a month in premium, which is literally in today's world nothing, right, for a single plan. I mean, most singles are what, $500 a month?
Right. Well, yeah, and if you look at from a monthly contribution standpoint for state or industry today, if you're on a family plan, typically somebody is paying, around $500 a month in the state, and that's about 35% of that total premium compared to the county, which, regardless of what plan you're on, they're going to be lower than benchmark.
The state will have to make the same changes due to IRS regulations. They'll have to bump up to the 6,200 or the 3,200.
Yeah, so it's from a benchmark perspective, state just means any, municipality, employer in the state of Ohio. But yes, to your point, Commissioner Jones, when we look at those deductible levels, those are, next year, when we look at it, it's gonna be up because everybody has to make that change.
Well, I'm in favor of doing what the IRS requires. What is the requirement?
The requirement is upping it to $3,200 for single and then $6,400 for family. And then the savings for that is pretty minute when we evaluated it. The savings really comes if we were to increase it to that $3,500, $7,000, and that $2,000, $4,000 for buy-up with the out-of-pocket maximums matching that on a 2x basis.
And that would still make then if they were paying a premium on the base to hit their deductible.
Yeah, there's no premium on the base.
Right,
Yeah.
I'm just saying hypothetically, it's like they could they're either paying a premium or there's a
Yes.
high deductible.
Yes.
But
Exactly.
if we didn't have a high deductible plan and instead had them pay a premium, even at the $3,500 proposed option that you're suggesting, that saves the county $300 and some thousand, it's still less than what a typical premium would be.
Correct. And looking at your historical data for your cost share for employee contribution, it's been at 15% for quite some time. I mean, you've remained very rich when it comes to what employees pay for those plans.
But most families, the deductible is $4,000, right?
For families, typical benchmark deductible is around $6,000.
Yeah, no, but I'm saying in our plan, you've got 4 sick children, hospitals, whatever, and it's all in network. What's your max out of pocket?
The max out of pocket for, depending on what plan you're on, it could be for base plan, it's $12,000, and buy up, it's $7,000 today. So that's your maximum exposure today on the plan.
But your proposed is going to what,
14 and 8.
Right, but if it's, so the out-of-pocket is the total, because, yeah, your deductible, you're paying 100% of that, and then your percentage on everything above it.
Correct.
So even at, your plan, you have terrible luck with the family, your total out-of-pocket is $8,000 for your entire family.
Correct.
On the
and
buy-up.
which is $667 a month.
But that's on the buy-up is the 8,000.
But that's where there's no premium. right?
No, the
No,
base
is
rate,
no
the
premium.
base is
Buy-up
no
is a
premium.
So the base families would be $14,000.
That's out of pocket, and then $7,000 on the deductible.
Correct.
But on that, one family member on the base plan would only have to go to 7,000. So one family member in a family unit wouldn't go all the way to 14. They would only go to 7 due to that embedded feature.
Correct.
And so you're saying, because I don't see that percentage here, but I think what I heard you say was that our employees pay 15% of their health insurance and the county pays 85% versus other public entities in the state of Ohio, they're paying 25 to 35% depending on, of employee cost share. And then in the, industry,
18 and 24.
18 and 24%. So all plans is 25 to 35 versus public sector plans is 18 to 24.
Correct.
And if we were to accept the proposed, what is that percentage of cost?
So the cost share for employee contribution that would remain the same unless we make changes to that. So this is just specifically on plan design. I was just putting the cost share in there so you can tell, yes, from a out-of-pocket maximum, it might be a little higher than benchmark, but when we look at it from a contribution perspective and annualizing that, looks a lot richer.
I don't understand when you use the word richer. Who's being riched? Rich.
Better, I guess, is a better terminology. Yes, better than
More
benchmark.
benefit is richer. It's a richer plan.
It
because
is.
It benefits the employees more.
Yes, it
It's
does.
richer than the market.
Correct.
Okay.
Correct.
So,
Or exceeding benchmark.
but our current plan is even richer than the plan you're recommending now.
So the plan that we're recommending would get closer to where benchmark is, specifically on the base plan.
But I mean, if you went up just as the IRS requires, that's a better benefit to our employees than what you're proposing, or maybe I don't know.
Correct. If you were to just keep it where the IRS is like, this is how much you have to increase it, that would be a better benefit than what
Right,
I'm proposing.
And
today.
my theory all along has been that this is a major benefit that we give to our employees. So I favor having the best benefit possible, which is what I've always argued for. So I'm in favor of going up to what the IRS requires.
And only that.
That's where
Yeah.
I'm at.
And the cost savings, if we went to the recommendation, is what?
The cost savings for the recommendation is $358,000. For the IRS regulation, it was just about 0.1%. It was very minimal, so it was pretty much a moot point.
I think the other reason a lot of times groups will go up a little bit more than the IRS benchmark is because next year or the following year, the IRS is probably gonna come back and say, hey, it was 3,264, now it's 3,468, so you're kind of hitting the employees year after year. So sometimes people will go up just a little bit more to kind of offset that every single year. Having to increase it due to IRS regulation, just another perspective.
Yeah, but we're always being ahead of that.
Would you want a recommendation or changes to the buy-up plan, or keeping that the same?
Again, I prefer to keep it where it's at, except but I'm not the only one here with this. That's just my feeling, because I want to have the best benefit to our employees as possible.
Allison, can you speak to the spread between the base and the buy-up deductible and how not changing, going to those limits and not changing the buy-up there won't be very much of a spread to encourage movement to the base plan.
Yeah, definitely. So one thing when we talk about this recommendation, and we had some conversations, I recommended if we were going to move one plan or increase it, that we increase the other plan as well. The reasoning behind that is your base plan today, although, it is free for employees, and your buy-up plan has a cost to it. If you are increasing the buy-up plan slightly, it might deter people to go to the base plan, right? Because if you're thinking about, okay, well, if they're both going up, or if one's going up or the other, trying to figure out what plan is going to be the cheapest for that individual. So if we do, say, make changes to an increase in the contribution for the buy-up, or, if there's reason to make a change, people are going to want to go to the one that's free. And so if people go to the free base plan and come off of the buy-up, that is less funding coming into the county because it's a free plan to them, right? So if they have claims, expenditure, et cetera, that's going to be more of a liability to the county because it's a free plan. So the migration of moving somebody from a buy-up to a base plan could cause some unfavorable costs to the county.
And the hedge to that is what?
So I would say if we were going to increase one plan, I would increase the other plan too and keep things consistent. Same thing for when we look at the contribution strategy. So if we're keeping, and that's on another slide, but if we're keeping the contribution strategy, say at that 15% for buy-up and keeping it at 0% for base, even though it's 15%, it's still going to go up slightly because the overall cost is, increasing. So if people see that their premium's going to go up, it could give them reasoning to move to the base plan. And if people migrate to the base plan, it's additional cost to the county because nobody's paying for that plan. Does that make sense?
Yeah, it does, but what's your point?
So I would just say keeping
Good
things.
for the goose is good for the gander. If we do one to one, we should do it to the other.
Yeah,
Keep it
and
consistent.
at some point, if you make the base so good, you're gonna have nobody on buy-up, and it's gonna be 100% county paid.
Right.
So, I mean, that's the balance that I think you're trying to strike here is,
Well, you wanna have an advantage to have go up. You wanna have an advantage to that.
I would say to Tiff's point, if you're offering a no-cost plan, which is very unheard of these days, and keeping it very competitive, overall, people are going to continue to migrate to that base plan.
But that's where we're encouraging them to be consumers, right? If they know they're paying dollar for dollar, out of pocket, and little Joey has the sniffles, you don't take him to the ER.
Right.
And that's in our best interest.
Right. At the end of the day, you want people to be good consumers on either one of your plans. But yes, making sure they go to the most appropriate place of care, et cetera. But they will not be paying a premium on that plan at all. So that money coming in to the county to help offset costs is going to go down. You know what I mean? Because right now in the buy-up, people are paying to be on it, and it's going into the county's, funds. On the base plan, there's no funds going into the county because it is completely free.
Right, it's basically, they're taking on an extra layer of insurance by paying a small premium, saying my out-of-pocket exposure is less. So that's that individual family's choice,
Right.
that employee's choice of, I want more insurance, not less. And I'm willing to pay a little bit on a per paycheck.
Right.
I mean, I appreciate Commissioner Grossman's comments, but I'm kind of thinking systemically over when people work for government. In a lot of cases, when I first started doing this, I came into one of the meetings and people got mad at me because I was like, are you kidding me? People were complaining about the healthcare plan 20 years ago. And it was, okay, yes, you make less in wages a lot of times than the free market, but you have three major advantages. Job security, for the most part, in the public sector, the retirement plan that's literally unbelievable.
Right.
And then number three is the benefits, the health insurance. And over time, though, that has become less important to our employees in the surveys.
wages have
It's
definitely
all
picked up.
about the wages.
Yep.
So that's where I'm thinking that, and through this year, with the inflationary pressures that was pushed on top of us, our wages at this county have increased dramatically, very similar to what the free market wages are, the private sector wages, I should say. So now it's like, okay, you've got private sector wages, but yet your benefits are still, according to every measure, way off the charts. And I'm saying keep them more attractive
Yeah.
than that, but to say we don't want, even though you just got large wage increases, that we're not gonna slightly tweak our health insurance plan design for, again, those that are the high utilizers will pay more slightly for that. I don't see that as a bad thing. But that's just my opinion.
I mean, I think that there should be an advantage by paying a premium. If you pay a premium as opposed to being on the base plan, there should be an advantage to that.
100%.
So I think it should be structured to give them a benefit. And so that we encourage people to say, hey, look, you get this benefit that's worth the premium you're paying for it.
Yeah.
So I'm in favor of structuring it that way. If that's what you're recommending, I agree with that.
Yeah, I'd say, yeah, the larger the spread obviously makes that plan that somebody's paying for that much more favorable and rich, right, for them to elect.
No, you're right, we want it to be a good deal for the employees, and especially they know they're a high utilizer, so they're willing to pay a little bit per paycheck.
Right.
That's a good deal for them, and it brings in revenue to
But
the plan too.
it could be a situation too, if they are a high utilizer and they know they're going to hit their deductible and the deductible is still fairly low or within benchmark on the base plan, if they know that's going to happen and they see, well, I'm not going to pay for premium, so I might as well go on the base plan because I'm going to hit it regardless, weighing that difference out too is something that employees might do.
Yeah, well,
If
I
it is still
expect them
small.
to do that. I don't mind.
Yeah, but that is a big spread, I mean, you're talking a lot of money between $8,000 and $14,000 out of pocket, right?
For family, yeah.
Versus paying a monthly premium.
Right. And that would be if you had a very catastrophic year, to Tammy's point, since it is embedded, if one individual hits the out-of-pocket maximum on the single, even though they're on the family plan, they receive benefit, right? So really looking at the out-of-pocket maximum on the family, that would be if you had a very catastrophic year where two people in your family had a lot of claims expenditure.
Or I've hit my deductible, so I might as well get my knee replaced this year.
Right.
Not
Exactly.
allegedly. I could go either way. I think at some point, and maybe this is not the year to do that, but at some point, the conversation around, for all intents and purposes, free healthcare, we're gonna have to grapple with that. I just don't know over time that that's something that we're gonna be able to continue to do, even though there is a deductible associated with it.
Yeah, there may come a time that you'll have to say, okay, well, let's just go to one plan.
Yeah.
And it might be a meet in the middle kind of thing. So, everybody pays a premium of some nature, but deductibles are kind of in the middle.
Yeah, and I guess I'd be curious about if there was if everyone was paying a premium, what the comparison would be to the county.
Right.
Because at some point, that's gonna shift
Exactly.
as costs keep going up.
So we really only have one question before us. We are gonna change to the IRS guidelines. That will produce some added income into the plan.
It
benefit,
will,
But it's
very minimal.
minimal, $50,000 or something.
Yeah,
probably.
it was like a tenth of, yeah, it's probably even less than that. But the thing with that would be typically how we structured it currently and last year was to double the out-of-pocket maximum. So I would need to know if you wanted to increase that deductible to $3,200, $6,400, if we would want to keep the out-of-pocket maximum doubled as well.
So if we're doing that, but then you're proposing that we go slightly above the IRS minimum,
Correct.
and clearly doing it with both plans, and you're saying that could save the plan 350 grand.
Correct. Yes.
So that's literally the only question.
And so, in the real world, the reason why we're saving money is because that money is gonna be spent by the employees.
Correct.
And the way that's gonna be spread out over the employees, how do you anticipate that?
So it just is based off, that plan decrement is based off of utilization today, of how many people are hitting out of pockets, hitting deductibles, et cetera. So it's just an actuarial
Well,
projection.
I'm asking you this question, so the people that you know in our employees that are paying money on this thing, where, is that $350,000 going to adversely impact a certain segment of our employees that we can identify? So there's gonna be it's not gonna be spread out over everybody, it's gonna be with a specific segment that are gonna feel this much greater.
Yeah, it's gonna be those who have hit their deductible or out-of-pocket maximum.
But we're
Or
only
who hit
talking
it.
about a maximum of either $500 more or $1,000 more,
Right.
right, for a single.
Correct. So, and just because somebody hit their out-of-pocket maximum today does not mean that they're gonna hit it tomorrow, or next year, but just from how many typically hit on your plan year over year, that's what that projected cost would be.
All right.
Allison, could you speak to, I know you're going to get to the preventive medication, that's 100%. Because of the preventive medication being 100%, employees are getting those prescriptions filled, and it's not subject to the deductible. So that kind of helps offset that a little bit.
Right, exactly. Yeah, so as you look at just overall what your plan offers today, you do have a lot of richness to the plan already, to Tammy's point, alluding to the pharmacy changes that would happen 2023. So even if we did increase the deductible, increase the out-of-pocket maximum, people are still getting no-cost prescriptions today that they didn't get last year. So that wouldn't change when it comes to the actual
So we're
plan
talking
design.
about a prescription that is providing you something that you take regularly in order to prevent something in the future.
Correct.
That's-
Maintenance medication.
Maintenance medications,
Yeah.
yep.
So if you have high cholesterol and you're gonna take a statin drug, that's free.
Correct.
Is that what you're talking about?
Yes, the list is pretty expansive though, because it
It is.
covers, cholesterol medication, high blood pressure medication, diabetic medication, insulin can also be covered, and
That's
that can
huge.
get costly.
Right.
So there are specific drugs on that preventive drug list
Right.
that are actually brand drugs that
And
are
if you
pretty
go out and you
expensive.
have, for example, you have a colonoscopy, that's completely covered.
Correct. And that's always been the case for colonoscopy specific screenings, yes. But the preventive drug list, there's been drugs that have always been covered at 100%. This list is just more expansive.
We've heard a lot from employees about how substantial that benefit it has been to them, particularly those who require insulin.
Yeah.
It's been just a massive benefit.
So
to
when
them.
you talk about raising the deductible 3,000 or 35,700, they're getting free medication as well. So
Good point.
And a lot of wellness
Lot of
first dollar
wellness.
benefits also.
See, but of course, my whole point all along has been, and Davis said this, is that this is part of their remuneration. We're paying them, we're providing this benefit. It isn't free. They're working for us. And so I see this as not a free thing, but I get, for me, this is a benefit we're providing as part of their employment because they're working for us and they're working for the county. And I agree, typically it's been of a lower amount of money. I think it still is over than what most of these people can get out in the market, but.
Yeah, I mean, my point is just that it's not a little bit better than the private sector. It's not a little bit better than most comparable government plans. Our plan is literally the Cadillac plan that I know of. Would you agree? I mean, you do this?
I would say from a contribution perspective, yes, it is a Cadillac plan. For both plans, honestly, of what people pay for their plan. As far as looking at the buy-up, for sure, when we think about deductible, certainly way exceeds benchmark. From a base plan, you are pretty much on par with benchmark when it comes to the actual plan design. However, to other things that you offer, for example, the expansive preventive drug list, not every private or public sector employer out there does that. So,
But the base plan is with no premium.
correct, exactly.
So that's my point.
Exactly.
But you can't really, that's not apples to apples, because, oh yeah, deductibles are similar. Yeah, that's when they're paying real premiums out of pocket every paycheck.
Exactly.
That's what I mean. Seeing
Yeah.
the health insurance world, most family plans right now are typically $1,200 to $1,800 a month.
Oh, yeah.
I mean,
Yeah.
they just are.
That Steve can attest to this too. I don't have any other client that offers a free plan these days.
So that's kind of my point of, we've been raising, because we listen to the employees, and they have told us consistently in surveys, that's not as big a deal as pay us our wages. Okay, so
Exactly.
we have done that, far outpacing the growth that typically we have done in wage increases, but yet we're literally talking about just tweaking the health insurance plan that is still unbelievably good.
Correct.
That's my point.
Correct.
Is we're just tweaking it to where the max for even the high utilization folks is $500 a year more, or $1,000 a year
Correct.
more. Worst case.
Exactly.
That's my point.
Well, and I guess the thing that I am focused on is it allows us to capture over a $300,000 savings in 1 year, for which the IRS is gonna make the adjustment, and that savings is not achievable any longer. I mean, unless we then go above and beyond again.
Correct.
And given where our rates are, it seems like a pretty, because the fact that we are able to manage the risk and manage the plan in a way where we're capturing savings, we're investing it back into the employees through enhanced benefits, whether it be wellness days, vacation days, and
Yes.
the prescription drug, expansive prescription drug benefits. So it's
Exactly.
not, it's not like we're padding our bottom line with it. It's a chance for us to provide more investment back into our employees. So I just see it as an opportunity it's gonna go that way anyway. The IRS is gonna make this adjustment every darn year. It's gonna be up there next year at whatever you're proposing for all intents and purposes. But in this year, we can capture some resources for the purposes of continuing to think about how we can invest in the employee wellness or benefit package. It is different than a profit motivation. We're not trying to just pull in more profits, but we are, because that money historically gets invested back in them.
That's a great point. Nowhere am I talking about profiting. This plan still costs the county $12 million, but it is part of the
Right.
overall compensation package.
Correct.
So it's an investment in the employees.
Well, it's part of your recruitment as well, and sell the sizzle.
Yes.
And we've talked about, we did the sell the sizzle tour to those that are under commissioners, and what you decide will be the same, and we will articulate just that, is preventative is this, here's where some savings are. That's what we're gonna have to have that discussion, because we've talked about it, Tammy and I did, and now Susan will be involved, is that sell the sizzle needs to be a yearly thing that they understand and appreciate. And I would just say, initial feedback from, not all obviously, but a lot of my coworkers were, their eyes were opened up. They didn't understand we were self-funded. They didn't know what they meant. They thought UHC was much more. So there was much more in those discussions than just kind of the nuts and bolts. a lot of their eyes were opened up to this, and we just need to continue that going into '24 with whatever plan adjustments you make.
So the increase in the pharmacy benefit, is that, contributing to the increase in the costs?
That's a good question. The pharmacy benefit, the expansive drug list, it is costing the county a little over $200,000, about $238,000 annually as an additional expense this year compared to last year. The reason of that, and Commissioner Jones, you alluded to it too, people are like, oh my gosh, I can take this now for free, this for free. And what we've seen on your plan is you've had a lot of people who have been on the plan and now they're taking these drugs for the first time. So although it is a significant increase, it's for people who probably should have been taking that insulin or should have been taking that drug
We're
last
trying
year.
to prevent the catastrophic.
Correct.
Case where we're at a $1 million plus claim because someone has
Correct.
quadruple bypass surgery.
Well, it's not just the savings to the plan, but we've actually tried to invest in our employees' lives with A Day for Your Life, doing the screenings, coming and doing
Exactly.
those things early. And again, it's worked.
Yeah.
In mass, our employees, and I guess the stop-loss numbers attest to that, I guess you could argue, are marginally safer or healthier now than they were at earlier points, because we are catching these really bad diseases earlier and helping mitigate that. Bad stuff still happens, but
Yeah.
we're catching it earlier. And so and that's a great point, that essentially it's costing us in excess of $200,000. So essentially by bringing in an extra three-something, we're almost just paying for that benefit. We're reinvesting that benefit back to the employees.
Exactly.
And the people that are using, I mean, they're
Exactly.
using it, they're utilizing that benefit, so.
Yeah.
To the tune, I mean, it's on the other side, but the tune of almost just under 300 new people, I think, are using
Yeah, I can go
items
to
that
that
they
slide.
hadn't did before, and whether that's low cholesterol to statins to other items.
I'll go to that right now just so you can see it. From a pharmacy plan utilization, it is up, obviously, your pharmacy spend. Actually, this is the wrong slide. Let's look at this one. One of those is because of the preventive drug list. So there was an increase about $238,000 annually based off of offering this preventive drug list. So a few key stats there in that box. There's a lot of words in there. Basically, what that is saying is that you've had people come off the plan, right? And you've had new people come on it. But of the 274 new members who have come on the plan, only 274 who have started taking these drugs for the first time, only 29 are brand new to the plan. All of those others have been on the plan and they're taking these for the first time. So we're really seeing an increase in utilization for just the uptick in actual scripts and people actually taking advantage of these free drugs.
That to me is as you all know, I have fought any sort of step therapy. I have fought, trying to limit our formularies because, people depend on increasing expenses around prescription drugs, and if you have a serious illness where someone is performing on a drug, the idea that we would take them off of that to try something cheaper, especially when you're dealing with some of the complexities of mental and behavioral health drugs, is ridiculous. But to be able to continue to do that, for which the benefit accrues to those who are paying, it seems just reasonable to me, Tom, that we make that adjustment where we can, because if you're reaching that deductible, you're a utilizer of the things that these enhanced benefits that we're giving. And so I don't see it as taking anything away. I see it as just a different way to invest those dollars back into the employee themselves. Because I tell you what, you could keep the same deductible and the same plan structure with then and add in things like step therapies and so forth. And people will really hate that, even if their deductible remains the same, because it's so, it's just such a tough,
Disruptive.
it's expensive and it's failing, it's not, people have to fail on drugs over and over again before getting some chronic disease under control. So I guess I agree with you, Tom, that it's like we're investing in our employees. They are getting it as part of their compensation for the work they do here. At the same token, I see an opportunity for us to be able to continue to provide some of these benefits, for which that's stunning to me that only 29 of the 274 are actually brand new to the plan, and we have people who should have been taking preventative drugs and we're not taking them and are taking them now. I mean, to me, that's substantial.
And I think as we were looking at this, obviously that 238 was something that we thought would be lower until we saw that these numbers were more utilization. And I think Allison has some things that she was going to throw out there as options to see if there were, if we want to keep it the way it is, or if we want to sit there and add some opportunities for reductions to the county. But I think that was sort of surprising to us. But I think we started to see it in the Sell the Sizzle tour. I just don't think we knew to the expanse of it because the data hadn't come in at that stage of the game. We were hearing it anecdotally, but not through numbers like we are now.
I would be less inclined to want to mess with that at this juncture personally, because you want people to be utilizing their maintenance medication to
Yeah.
prevent some sort of catastrophic occurrence.
And typically what we see with adherence to these drugs, obviously your data is still a little immature that we can't do this study, but typically what happens is we do see a decline in medical spend, a better trend on medical, because people are taking care of themselves proactively, so hopefully catastrophic things don't happen in the future.
Yep, I mean, look, that I think is really wise on us to do that and to make things free or free when it helps them to reduce our cost in the future because of illness, et cetera. At the same time, the countervailing point to my argument all along is that if you have health care completely free, then people they're not as worried about wellness. They're not as worried about maintaining themselves because they think, whatever happens, you're going to pay for it. So I think that there should be a cost. And I see that's a countervailing argument, which I think and Dave is pointing out with the market, and of course that's an important part of this too, but at the same time, so I'm willing to do whatever you guys want on this. I still favor making our plans as rich as you talk about, using that term as possible, because I want to attract good people with this. I get the fact that ultimately people care more, always have cared more about their bottom line, how much money they make, than what they might incrementally spend in some other way, because they'd rather get more money over here, and as long as their spend over there is less, that's of course what they prefer. Okay, so we've got to
Good
get
with the
going on this.
recommendations at 35 and 7,
If that's what,
7, 14, and then on the
Because we're
bio.
only talking about a little bit more, the IRS is
You're right.
forcing us to do a lot of this.
little.
We're only talking about tweaking it
Adding
a little bit
about,
more.
$300 to, or this,
okay,
yeah.
all right, then I'll go along with that proposal. Shannon, you there too?
Yeah,
Okay.
Okay, very good.
So for both plans.
yes.
All right. We talked about the cost share, so wanted to give you some options as far as what the overall increase would be for the cost share to employees. I have two slides here, and we can go back and forth. This first one is if we took the suggested department increase of 4% to total fully insured equivalent rates. So the total rates, what that would do is if we would keep that cost share the same as it is today. So 15% on buy-up and then 0% on base. What this does is it essentially increases the buy-up premium, $3 monthly for employee only, and then for family it's about $10 on a monthly basis. That is if we keep it at that 4% increase. I'm going to go to this next slide really quickly, because this is the other alternate option, is the 7% increase to total rates, keeping that cost share exactly how it is today. That change, the difference in premium for the buy-up, employee only would be $6 a month compared to the $3, and then family would be an $18 increase a month compared to the 10 with a 4% increase.
I'm okay keeping it at the 4
Me too.
if we're increasing our deductible.
Okay, I'm all for that too.
All right, a few other medical plan recommendations that I will go through. This is one that United Healthcare is offering to all of its employers, municipalities, et cetera. This program, it's called NRS, Neonatal Resource Services. It has been around for a while, but it's always been an upcharge of like a per employee per month charge. They're trying to implement it with a majority of their clients going forward. And so how they're doing that is they're moving it to a case rate cost where it's $1,700 per episode. Basically what this program is, it's clinically guided extra support for babies and their mothers who are in the NICU. So there's a team surrounding them with board certified neonatologists, I can't even say that word, nurses, NICU, condition management support, just extra support overall. Really from like what this would charge the county, you've had very minimal utilization in NICU, which is fantastic news, specifically related to the benchmark for United Healthcare too. Last 12 months, you've had 16 newborns on your plan, and you've had 1 NICU baby that is below their benchmark. So overall, I would say this is just a win-win if, somebody needs that care, extra support, helps them even after their discharge for 12 months, manages any support they need. It's an additional benefit that you can offer your employees.
I don't understand what it is, though. I mean, I've had twins that were in the NICU, and what, they were there. You got they were covered under insurance.
Yes. Yeah.
And subject to my deductible and all that way back when, but.
So it's extra support. For example, they collaborate on your plan of care with the hospital. They make sure that you have timely procedures, proactive discharge planning. I know sometimes if you're going to be discharged, they say you're going to be discharged at this time. It takes many more hours to do it. You have another team that escalates different things like that. The nurses assist with more escalated overall facilitation. And then, like I said, it provides ongoing support for 12 plus months after you are discharged.
I just don't understand that once you're in that unit, so you're saying, okay, you pay an extra fee to your insurance company, you're gonna get someone that's gonna take care of you more than the person in the bed next to you. I don't buy that.
Well, I think it's whether you pay either per member per month or you pay
Right.
for the episode. It's not
Exactly.
that the care is different, it's that they're not charging a per member per month as part of the NICU special care nurse rate
And
stuff.
it's, I understand to be more like case management
Yes.
type
Exactly.
situation.
Wait, so are we getting this?
You don't
now?
have this today.
No, no. That's
No,
it.
but it's just a question of whether or not we pay per member per month, or we would pay.
Well, it's an opt-in or out. It's an
Well,
opt-in
yeah.
or out. You
Yeah,
don't
no.
have to do it at all.
Yeah, my question was,
Right.
what is the upside of doing it?
Yeah, so
Is-
they went away with the per member per month. So it's if you want this, it's just a case rate for any specific person who qualifies. So if you had this today, you would have had one person who qualified in the last 12 months.
So what does that mean, from the cost of the plan?
It would be $1,700
Per case.
per
Per
case.
case, and that's, the county would pay that.
Correct.
Okay, I'm in favor of that.
And then you could see at the bottom there, I mean, from a member
I mean, it
satisfaction,
might
it's-
cost us, since we had one case in a year,
Yeah,
Is that
out of
right?
16.
Yeah.
$1,700, one case?
Mm-hmm.
Okay.
Yeah, I was just philosophically, I don't understand what extra care they get discharged quicker. I mean, I don't understand.
Yeah, so I would just say more of like a concierge case management support. You can see from the ROI, there's demonstrated ROI even for people who have this in place today, driven a 6% reduction in length of stay at the hospital, related costs, readmission rates, those type of things, which are, proven
Insurance
from.
companies like this?
Just, yeah, another way to, from a fully insured perspective, if they're paying the claims or you're paying the claims, they want to make sure that readmissions are down, people are healthy, and they get the care they need.
So to Dave's point, where he doesn't, I get what he's saying, he said, well, what? I mean, you mean, I'm in the thing either way, but I'm in the thing with this, and I get, like, special person's gonna come in and really help me understand the benefits.
Yeah.
To help me get off this thing faster, and Dave's point is, huh? Why would that happen?
Right.
Well, if they're gonna, it just really is gonna depend on the acuity of the baby, right? So it's like we have one a year, and.
I'm in favor of
and-
doing it because it's not very much.
Right.
And it's gotta be something.
But if you're a parent and they're gonna discharge you and you have to do a feeding tube,
Right.
I could understand why having somebody that you could call would be beneficial.
Right.
Okay, well, so I'm in favor of it.
I'm in favor of it too.
All right. All right, from medical plan, another thing as far as just due diligence recommendation is a dependent audit. This is something that has not been done for the county for quite some time. We typically recommend to do whether a claims audit or a dependent audit every 3 to 5 years, just to ensure the people who are covered on your plan are supposed to be covered on your plan. As far as the cost here, right now, there's a total audit cost of about $15,000. Projected savings from BMI, which would be the service that would do the audit, independent TPA outside of United Healthcare. Their savings are within $246,000 to all the way to $600,000, depending on how many people, aren't necessarily supposed to be on your plan. Right now, you do have a lot of good due diligence in place today with your spousal parity rule. So a lot of this could be attributed to dependents on your plan. Every year, Faith and Tammy and the team do a great job of making sure that people who cover their spouses are in fact, they do not have coverage elsewhere, and they do audit that every year and just get supported documentation. So a lot of this, like I said, would be for, thinking about some of the dependents who are on your plan. Are they really supposed to be on your plan or not? That chart right there is showing you from a potential annual savings, actual Warren County data for how many people are enrolled. You do have a high contract size, meaning you have a lot more people on your plan than other plans. One reason for that is you do offer a free plan, right? So if you have a family plan that costs $0, and dependents can join on that.
So this
they'll
is
join
kind of
it.
simple. So for 15 grand, we'd get an extra, someone looking at it, even though Tammy does do a great job, people aging off the plan, the spousal parity rule, which was something we did a long time ago, which was really important, I thought.
Correct.
Yeah, I got no problem with that.
Yeah, absolutely. It's
It's good
obvious.
practice.
You're sure, you do an audit and you save multiple times the amount. Okay, good, we'll do that.
We could probably go through some of this pretty quickly since we've discussed the RX plan. Just high level, pharmacy spend is up. It is part of why that budget increase, we're seeing it exceed budget where we are today, 2023.
Yeah, you already went through this, I don't think you need to
Yeah,
do it
so
again.
the only thing on this is separate from,
different?
This one's different than, and this is the thing from the preventative to this, because I wanted to make a distinction, and I did with the team, was I thought that the board, at least in my opinion, would be in favor of the preventative, but I think we need to make sure that you're at least understanding the specialty drug costs to the plan.
yeah. So $238,000 is attributed from the preventive drug list. Where's all the other increase coming from? This just gives you a high-level overview on that. The rationale is on the left-hand side. But the big thing, to Martin's point, is specialty drugs are increasingly expensive every year. The trend is wild. So looking at this in particular, you have 6 drugs on your plan, 6 claimants that are accounting for almost $500,000 in spend. So when we think about that increase in cost and where it's coming from, specifically on the pharmacy, yes, there is some coming from the preventive drug list, and it's more than we anticipated, but a lot of it is coming from these high expensive specialty drugs. Typically just have one monthly script, one claimant a year, accounting for a majority of that spend.
I don't even know what those drugs are.
Yeah, me neither.
Yeah,
I never
and
heard
they're
of
hard to
one of them.
pronounce too.
I did look them up. The top one's breast cancer,
Yeah.
MS, pulmonary high blood pressure, spinal muscular atrophy, Crohn's, and another cancer one.
Well,
Yeah.
you should still cover those. They're expensive, but
Yeah. Oh, yeah.
people with breast cancer should get their
Yes.
treatment.
Yeah, no recommendations as to taking these off by any means or
You're
anything
just
like that, just
informing us of
rationale.
this.
Right,
Yeah.
just
I get it.
for the overall of what the plan spend
Sure.
looks like and what's attributed,
Gotcha.
what it is
Thank you.
attributed to.
I will tell you your top condition that increased for spend was diabetes. There's expensive diabetic medication, insulin, preventive drug list. That is one of the largest conditions that we saw.
And by the way, people who are getting diabetes, is that largely based upon their lifestyle?
It can vary. I mean, the type 2
No,
diabetic.
it's like they're not eating well, they're not getting exercise, they're doing things that they shouldn't do, and they get type 2 diabetes.
A lot of it is lifestyle prone, yes.
Right, and that's our wellness program and all that stuff is meant to prevent that.
Yeah.
Okay.
Yeah, and I would hope with seeing your medical trend in the future with offering some of these drugs for free, specifically a lot of these high, utilized diabetic medications now, hopefully we see a better trend with that too. So I feel like I could probably fast forward through this one.
Yep.
Yeah, okay.
Keep it moving.
I did bring just a few plan recommendations on pharmacy. We don't have to spend too much time on this, but when we look at specialty spend in general, it is high, right? So what are some things that we can do to offset some of those costs? There are 2 programs that Optum Rx does offer that I wanted to bring to your attention. These are basically designed to optimize finding the right medication for the employee. So I wouldn't say step therapy, Commissioner Jones, but I would say as far as just making sure that how somebody is utilizing those drugs is the most appropriate and efficient for them. So specialty standards is one of those. Based off of your spend today, that savings is around $100,000. This is trying to find the right medication at the point of prescribing the medication. So what I mean by that is an example would be, I have one as Cosentyx, for example. Cosentyx, you could be administered 1 pen or 2 pens for Cosentyx. Obviously, depending on how it's administered and the dosage from that, it can be the same dosage, but it could be 1 pen or 2 pen, and that can affect the cost. So what this plan does is make sure, okay, if we can just have 1 pen rather than paying for 2 pen, same dosage, why wouldn't we, recommend that to get the savings?
Meaning it has 2 doses in a single pen.
Correct. Yes,
But
exactly.
you're not really changing the doctor's ability to prescribe to his patient what he thinks is best.
Right. It would just be the
'Cause
actual.
I wouldn't, I could imagine an insurance company saying, there's this drug that performs this well with this particular problem. And then there's another drug that's way more expensive, but performs a lot better. But you know what? We're only gonna pay for the lower cost drug.
Exactly. This is
We're
keeping
not
the
doing
same.
that.
But we are kind of doing that.
Just-
Because it just happened to me last week. With my asthma doctor, went in and wanted to put me on a new recurring treatment, and he's like, but I'm not sure, I was on one before, and with the new one, he said, but I'm not sure your insurance pays for it. Somehow, his office checked, and it's not paid for, so they put me on my old one, even though he thought maybe marginally I was gonna be better off with the other one, but it wasn't covered by our insurance, so we do that.
It could just be from your formulary or your prescription drug list, what's covered, what's not covered. You have the widest, most open formulary through Optum today. That still means it's not going to cover every single drug. So that could be.
Yeah, I'm not really complaining, I mean,
Yeah.
because it is a cost, but, you know, if it was like
See, I
absolutely.
was using my example on this, Dave, and you're taking my example as, actually, that's occurring, although this is not causing it.
But those are two separate drugs. This
Yeah.
would just be the same
I
medication.
mean, your recommendation here wouldn't cause the problem I just mentioned.
Correct.
Because I was mentioning it, if this doesn't do that, and then Dave is saying, yeah, but it is happening.
This program would not say, hey, you know, you're taking this drug, maybe we should take this drug instead. It would never evaluate that.
Well, I'm in favor of doing this,
Okay,
okay?
Yeah.
You guys?
Yeah, as long as, Commissioner James's point, we don't want the insurance company dictating you have to take it.
Right.
Correct.
I agree with that too.
yes.
Even though
And
it just happened to me last week, if I didn't
Which,
mention that.
that's rare. I mean, we
Yeah.
very rarely ever hear that, so I'm wondering if there's not something.
I think something might be wrong there. Yeah.
I've been told there's something wrong with me for a long time.
I mean, it could be a formulary issue though, too.
Which
Yeah.
doesn't really
Something
happen
doesn't
that
that
often,
often,
like, I mean,
yeah.
it's new,
I
yeah.
can't remember the last time we had somebody say, this wasn't covered under our insurance.
Generally, if it's
Yeah.
a covered class of drugs and has the NDC code on it, our plan.
Tammy will check it out.
Yeah, we'll check it out for you. So yes, that's specialty standards, keeping the same drug, just administration, or when you're getting it prescribed, just evaluating that. Review My Care is the other one. So basically, this is going to pair you with another case manager.
Yeah.
Kind of
Looking at
thing.
my medical records.
Yes, reviewing that and just ensuring that the dosage you're getting.
That's fine.
Yep, you're good? Okay. That was easy then. But yes, no, minimal disruption to employees for changing drugs. I don't know if we want to review this from a time perspective.
Our attention deficit kicked in. We should be on.
This is something you probably won't want to do, but we wanted to bring it as an opportunity in the future. There are employers who are actually carving out drugs from their plan to leverage manufacturer assistance, coupon codes, et cetera, which saves the employee money because they get them for free typically, but it would be carving out of your plan. So there would be disruption for minimal, but for those people taking those specialty drugs.
Yeah, probably
So I will-
until that process gets more cleaned up to where there is no disruption. Because I get, you know, you can do this, or this program will pay for it. Those are all fine and good, but if it is actually disruptive to the employee.
And
Yeah.
you can actually use it, I mean, you may not be supposed to, but you can use the coupon and not put it on a claim.
Correct. That's essentially what that program would do. is
But I can
taking-
already do that as a consumer.
Exactly.
Okay,
Yes.
you
So it
can
could be
move
just a communication effort to your employees. Correct. All right. So getting out of medical, we're going to talk about dental. Everybody's favorite topic. Wanted to end with that. We did do a market bid after the, with Dental Care Plus coming and making sure that we have the most competitive dental contract. We did evaluate a few different carriers. So you all being ASO, Administrative Services Only, self-funded, the charge that you would pay the actual carrier is that administrative fee. Looking at these, I will tell you, Dental Care Plus does come most competitive when it comes to administrative costs that you pay. They are willing to extend your rate guarantee as well. If we want to do that, we can certainly open up a market bid in the midst of that too. The big thing you want to see is the network disruption. So the last time we came, we talked about, okay, how many dentists are actually in network within the county? So I want to make sure you all are aware that 94% of your subscribers utilized an in-network Dental Care Plus provider in the last 12 months.
Yeah, I just heard that was changing. I asked Tammy about that one, that more and more dentists are dropping Dental Care Plus. And you're saying that is still the highest utilization?
Correct.
Delta Dental looks
Delta
like-
Dental is, as far as in-network today, Delta Dental is creeping up there, so I would say that they're probably a little bit more favorable today. However, with the Sun Life acquisition with Dental Care Plus, the Sun Life network is going to be merging with Dental Care Plus. When we evaluated that for Warren County, that means you're going to have an additional 16 dentists that are currently out of network come in network effective 2024.
And that
Okay.
will mean that then Delta Dental Care Plus is better than Delta
Correct.
Dental. Okay.
They have beefed up their network.
They have,
Okay.
they have.
I mean, my dentist, I talked to the Dental Care Plus about it. My dentist went off of it because of the administrative hassle.
Yeah,
And they said they're gonna try to correct that. And it turned out my dentist was on their board of Dental Care
Yeah,
Plus.
it was dentist owned at one point, and then
yeah.
they got out of the business, but it's better.
So what I will say, as far as how we make it better for those 41 dentists that will be out of network in 2024, is how we make that reimbursement, if people want to stay with their dentist, more favorable. Right now, you have, the out-of-network reimbursement is called a match, which basically the patient pays the difference for what is charged or what DCP would pay for an in-network service. If we wanted to look at this chart and go all the way to option 3, there would be an additional cost to the county, about $30,000, because you are going to be paying for more claims. However, what that would do, that would move up the actual reimbursement amount for those individuals who are going out of network. Richer benefit, I'll say richer again, reimbursement, because it's going to reduce the impact of balance billing, because the actual benefit that's being reimbursed is higher. So ultimately, I would say, long story short, 90th percentile is going to be your highest reimbursement.
But you're just talking about something you're gonna do in the future, of bidding this out, or is this right now?
You could do this starting effective January 1.
Well, I mean, I am in favor of, given the fact that we've got people who are complaining about not being in network, that the out-of-network people be provided the same benefit as in-network people. I'm in favor of that. The other thing about dental stuff is we now know that dental stuff is very important to your heart health.
Yeah,
And it's really important for preventive medicine, because people don't realize that if you don't take care of your teeth and your gums and things like that, it actually affects your cardiac condition.
yeah. So Commissioner Grossman, at that point, what you have today is kind of matching what's in network, but you have opportunity to be balanced billed. So Dental Care Plus will pay for the same in network, but then that difference of what that dentist is paying is ultimately your responsibility being out of network. If you move to the 90th percentile, what it will do is it will take that payment even higher than maybe even what it is in network. So ultimately, the goal is to make sure that your costs as a member go down and that you don't have balance billing anymore of, what's the difference, what am I gonna pay? So that's why it's gonna be an additional cost to the county of around $30,000, but it benefits the member from what they're paying on network.
Yep, I'm good with that too.
So hopefully that would, calm anything from out-of-network
Right.
perspective.
I like that. And I really want to encourage people to be careful. People are not doing what they should with their dentist.
Yeah.
It's extremely important for their health. They don't realize that it's just not their teeth that's involved. And
Agreed.
people aren't educated to this. It has an overall effect upon your body's health. All right.
All right, this slide can be really quick. Your life insurance isn't a rate guarantee. We did extend that. They have not increased your rates in, a very, very long time. So they've been a great partner of yours. IMED's the same way. And your claims are projected to decrease based off of the funding rates we provided. So that's all.
Great, get out.
Okay, thank you.
All right,
We got an
thank you.
executive session we got to go to now?
Yes.
I'll make a motion to go into executive session on pending litigation with legal counsel present pursuant to ORC Code 121.22G3.
Second.
Roll call, please.
Mrs. Jones?
Yes.
Mr. Grossman?
Yes,
Mr. Young?
Yes. Thank you.
Thank you, everyone.
I've signed all this stuff.